Is there a particular part of your story of coming here that really fits into, I guess, this theme of the economy of trust in terms of your decision making early on to make Goshen your home and ultimately pursue this vision that you've had for a community-based healthcare?
Yeah. There's been huge amounts of just grace all along the way and sort of surprising levels of generosity from so many people in the community in this whole Maple City venture. And so trust is kind of hard to take out of that. When I was in college, my second year in college, I moved out of the dorm late in the semester to be part of a little household of members of the Assembly congregation in North Goshen. And we were thinking about issues about how does the church bridge the divides in our society the way the early church did in its. And we didn't see the divides being between Jews and Gentiles, but rather being between relatively rich and poor, and educated and less educated, and all those dynamics. And at that point, Goshen was not very Latino. The census, the last census, the census then was like 3% Latino or something like that. But we had lots of folks in North Goshen who were transplants from Kentucky and West Virginia and Tennessee and worked in the rubber factories and those kinds of things. And so we lived in that neighborhood and were engaged in a variety of things from bilingual education to the county home, which was a place for indigent people to be engaged in community life. And it was really in that context that I started seeing how many people didn't have health care. And wondered about continuing that engagement around building bridges through healthcare. So I really went to medical school not to become a doctor. I went to medical school to do this project. And then when I came back, I found this incredibly welcoming community with that. We started a board around a bunch of people involved in tenants organization and minimum rental standards in the city. But you know, I mean, there was this. I had nothing but debt and passion, and we just kind of dived into this stuff. And the community was trustworthy, and things came together. You know, and then all of a sudden, out of the blue, the mayor calls me up and says, "You know, it sounds like you've got a project looking for a building. I've got a building looking for a project. Can we get together?" And they gave us $25,000 to renovate the old fire station. They estimated it would cost $70,000, but with all the donated labor and all the donated roof and the donated electrical and the donated, we did it for 25. And just kind of, you know, it was at every step of the way a kind of providential trust-building venture. And that built the spirit for the place to start with. We didn't have a business plan with a balanced budget. We had a commitment to a community and some relationships, and we kind of played with it to see what would happen.
Mm-hmm. So when I asked you before the event, just to confirm your title, we clarified that it's not guardian of the vision, it's guardian of a vision.
It's guardian of vision. And so part of what my job is, and we think of this as the most central leadership role, is to keep the organization focused on vision, not on bottom line, not on survival, not on, but how do we keep focused on a vision for what we're trying to do in the community? So John Driver, who's our oldest board member, said a while ago, and there was a quote up here a while ago from him. He said, you know, people think that because we do healthcare, we're a medical organization. We're not. We are a peace and justice organization engaged in community development whose entry point in this neighborhood is through healthcare. Now, that's not how everybody would necessarily articulate it, but there's that element of a vision for community, which really underlies it, and which I think allows us to then do healthcare incredibly well because it's really not about the healthcare. The care is a manifestation of the community that's forming. It's not a goal in and of itself. It's not a commodity to be sought or purchased. It is something organic that develops in the shared space.
One of the aspects of that visioning that I've often heard you talk to is imagination, mm-hmm. and the key to the imaginative vision as a way of helping you see then the potential. Once you've mm-hmm. opened up that space for that vision to manifest, it takes this infusion of imagination and creativity to help give it life. So I wonder how that fits in as well, because you're ultimately not trying to, pick a vision that already exists. You're trying to do something new. So how does that?
We're trying to do something authentic, and because our context and the people we're working with is ever changing, it by definition has to be always new. So it's not that we're trying to do something new for the sake of being new. Right. We're trying to work with what we have and the assets we have and the community we have, and that leads us to always reimagine things in new ways. So the way I think about imagination is that it is always a manifestation of people having enough. The sort of the most the quickest killer of imagination is fear, and scarcity is at the heart of fear. And so part of working at fostering a community of imagination is fostering a community where there's enough and where people have that sense of there being enough. And so that's been part of what we kind of have worked on over, and that is a collective process. That's not, we have some leader who has a vision with imagination and imposes it and gets everybody else to do their work. And no. It's about people thinking about things together. So for example, in 2008, when everything was tanking around here, estimates were that our Latino population, that of the undocumented people in the Latino population, there was 80% unemployment. Chamberlain Elementary School was giving 100% of their kids free lunches, free breakfast, and sending home food packets over the weekend because kids were going hungry. And we'd always had sliding fee discounts for everybody, but we'd never had free care. Because we always had a sense we want some kind of engagement, we can argue with whether financial engagement is a necessary component, maybe not. But we always had sought some kind of patient engagement in care. And all of a sudden, folks were dropping out of care because they couldn't afford it. And $5 for an office visit was $5 less food for their kids. And so if they had to have a choice, they were going to spend it on food. And we started seeing people dropping out of wellness care, dropping out of diabetes care, and we were devastated. And we're sitting around the lunch table staff meeting, and somebody's asking the question. And this is the only reason this question came up is because we are constantly asking and visioning questions of each other. And the question came up, so if people don't have money, what do they have? What do they have? What are the assets? We're talking about asset-based development. What are the assets? And the obvious answer was time. And so within 2 weeks, we had the More Than Money program, which was where people could volunteer anywhere in the community, and we would give them $10 an hour credit on their healthcare center bill for their volunteer activity. And all of a sudden, we saw people coming back in with care, who had been drifting away. We'd had one guy who his family had a $1,000 bill. Now, when you're getting 90% discounts, a $1,000 bill in primary care, that's a lot of health care. And he would still come in, but he'd always come in kind of with his head drooping and just not very. And he and his son went off to be part of La Casa's Help a House for a week and volunteered for a week. And he came back with $1,000 worth of coupons for his health care bill. And he came in and said, "Ahora puedo pagar," with this huge grin on his face. So we knew it was working. It came out of corporate imagination and engagement about what can we do differently and what can we build this on.
That's fantastic. I think speaking to that sense of finding abundance in terms of asset-based community development and the gifts of individuals. Just recognizing that if you, I mean, as a healthcare agency, if you see people as patients that are arriving with a need, a deficiency, you're stuck. You know, how do you grow from there? But to see people as members of your community arriving with something to offer really is empowering. It really is unlocking the potential of your neighbors. What are some of the other, I mean, so Maple City has done, it's been easy for me to really come to appreciate the role, the work of Maple City Healthcare Center in the community through the stories that they've archived and collected on the website, many of which you and your wife Barb had contributed. But they speak to a lot of these, I mean, they're anecdotal, but they capture the essence, I think, about how these things transpire on a, you know, on a case-by-case basis. So I really encourage folks to explore their website. Now we've tried to gather and catalog a lot of these stories through the Goshen Guide and through some of our, and through the collection that we prepared for this event, just to try to help offer some more jumping off points and make them a bit more accessible. But really going to the Maple City Healthcare Center website is a way to discover for yourself some of these stories that capture some of this. What are some others that speak to this idea of really empowerment and in creating space for people to contribute their gifts so that you're collectively building a healthier community?
So one of our early stories, and we think stories are important because they shape our character. So they help remind us who we are. So we think the role of story in the organization is important. It helps us. We try very hard to be telling stories among the staff. We have story circles all the time, because story is how we remember who we are and what we're about, and then we don't have to remember all the policies and procedures and everything we're supposed to do all the time, because we can live out of our character as it's shaped by that. So we actually have a chief storyteller, Don Yost, who gathers stories and puts them out there. He also writes some very compelling grant proposals, which are ways of telling our story to people who might want to help fund it. But so storytelling is important. One of our sort of core stories that we've told for years is about a couple, I'm going to call them Jose and Maria, I guess, for these purposes. They had 2 young children. They lived in a little decrepit apartment. And she was pregnant with a 3rd child, and came to us for prenatal care. And they were undocumented, and we tried to get them on emergency Medicaid for her pregnancy for the hospital, and ran into all kinds of problems with the welfare department, who said that Medicaid is not available for undocumented people. And we contested that and worked through it, and eventually got her emergency Medicaid. To our knowledge, she was the first person to get emergency Medicaid in Elkhart County. And she had her baby, and everything was fine, and she went back home. And then a while later, she developed gallbladder disease. And now the emergency Medicaid didn't apply. She needed to have a surgery. She couldn't afford it, and so she put it off and ended up with a septic gallbladder, extremely sick, in the ER, in the ICU, having had surgery, and eventually recovered, but had a very expensive hospital stay. And so they came back with this huge hospital bill and they came into the office with it and said, "We don't know what we can do with this. Can you help us talk to those folks about it?" So one of our staff went with them to talk to the hospital finance people. And these people said, "You know, we'll pay what we can. We can pay $20 a week, you know." And the hospital just kind of scoffed at it. It was painful and embarrassing for our staff. They didn't know quite how to handle it. It was just very difficult. So we came out of that committed to really sort of doing some advocacy for them, and finally persuaded the hospital they weren't going to collect this money anyway. They might as well at least make friends with us. So they canceled the debt. So these people now didn't have a hospital bill anymore. They just had a surgeon's bill, an assistant surgeon's bill, an anesthesiologist bill, a radiologist bill, an ICU doctor bill, an ER doctor bill. You get the picture. So we wrote a letter to each of these doctors explaining their situation and saying the hospital had canceled their debt, and if they could do anything, that would be appreciated. And 7 out of 8 doctors canceled the debt completely, and the 8th one said, I'll give you $10 credit for every dollar you pay. And they were totally delighted, and we felt like, okay, we did some advocacy, there was some charity involved, things worked out, this family got what they needed. We're happy. End of story. Well, a few weeks later, these people came to us and they said, can we borrow your community room? And we said, well, it's usually available for community organizations to use and stuff, but not usually for individuals. What did you have in mind? Well, we are so grateful for what all these people have done for us that we would like to invite the healthcare center staff and all these doctors and their spouses and the hospital administrator to a dinner. And they saved up, and we sent out invitations. And as in the story of the Great Banquet, not everybody that was invited showed up. But a bunch of us did. And here there were people around this table, some speaking Spanish, some speaking English, some translating. And as we sat around this table eating this lovely, simple Mexican feast, we suddenly realized that we were the guests and they were the hosts. And the tables had been turned and the relationships transformed. And it changed everything. And it wasn't because we had a program to do this or a program to do that. It happened in the gaps. It happened in the space that was created in the midst of that by their initiative.
Yeah. I mean, we alluded to asset-based community development as kind of a framework or a very open process for focusing on the gifts of individuals. We had the privilege of going to a one-day training last week, a group of us from Goshen, focusing on that application for faith-based communities. But the thing that they really focused on is, blessed are those who give, or it's, it's better to give than to receive. It's oftentimes what we take and we apply that to uplift charity, give how good it feels to give, but that how often it is then, especially in our institutions, that we rob people of the opportunity to give themselves, to give back. And so that's what I see happening in these spaces that you create, is you're empowering people by providing them opportunities to give. And I think that's a model that to see spread broadly is wonderful. And I guess, it's not a programmatic thing, right. Yet you do have programs that by design hold space for those gifts to be given, not necessarily to Maple City, but amongst each other.
Sure. I mean, I don't think there's any human need that is much greater than the need to be needed, the need to have something to contribute to the human family. And almost everybody wants to do that. And so how do we help people identify? So whenever we face a situation that looks like scarcity, it's, to my mind, a challenge to be more imaginative in how we relook at that from a new perspective and see their opportunity, and see there some gifts, see there some capacity for a different kind of engagement, a different economy. This economy language again, I've got to bring a little bit, because it seems like we tend to think of, in this country and in healthcare, which we think of as a commodity or an industry, we tend to think of the efficiencies of scale and the economies of scale and efficiency and savings. And I am increasingly convinced that trust and the trust that comes out of trustworthy relationships has far more to offer in terms of economy, dollar economy, than anything we can do with scale.
Well, I would, in that context, think of trust as a currency, if you will. I mean, it's what energizes or what gives fuel to the formation of the relationships that are holding this healthy community together.
Sure. And it leads us to places that are sometimes uncomfortable and that don't always fit with our usual models of what is a professional relationship. I mean, I have this patient, I'll call her Karen, who has been a patient of ours for decades. She has some behavioral health issues. She's diabetic. She has a very dysfunctional family. She's depressed. She has all kinds of things. She's low income. She's getting kicked out of houses all the time. She's kind of a chaotic life. But she has found us as her medical home, and she always, she'll come in and she'll cuss people out, but she always comes back and apologizes, and she's always still engaged, and she always calls me honey. So one time she was in for a diabetes care, and I was looking at things, and I said, by the way, you need a tetanus booster. And she said, I don't need a tetanus booster. I don't know anybody with tetanus. I said, well, that's not how it works. You know, this is how you get tetanus, and you need a You mean everybody needs a tetanus booster? I said, yeah, everybody needs a tetanus booster every 10 years. She said, well, when's the last time you had one? I said, well, I just had to fill out some paperwork for the hospital. It's been 12 years. She said, well, I'm not getting one till you're getting one, and I'm not going to believe it unless I see it. So I had the medical assistant come into the room, give me my tetanus booster, and then come in the room and give Karen her tetanus booster, okay? And a couple days later, when I was calling her back about her test results, she said, so how's your arm, honey? I said, well, it's okay, but it's a little bit sore. She said, well, mine's just fine, so there. Anyway, so trust builds over time, and it builds over all kinds of ups and downs, but it's about ongoing companionship, that we don't abandon each other. That's what trust isn't about fixing things. Trust is about being there.
So, and which are these relationships that you're very intentional about, that are integral to everything that Maple City Healthcare Center does. So you have these, your circle groups, your different groups, which then are another place for nurturing those relationships. But then they're also creating these opportunities for you to still do healthcare, but at times in a way that's would be tough to fit into an appointment or do, at the frequency that you might otherwise want to. So from having this interest in Maple City's work and the way these different programs are functioning, you were gracious enough to invite me to participate in the Healthy Living Circle, this past year, which was a really great way for me not only to benefit from the group and, challenge myself and do that in a community, but of course to see how you work. So these groups, do you want to speak any more to what are some of the successes within these groups that have really kind of created or generated trust that have really have translated into your ability to provide healthcare or help provide for a healthier community?
Well, the first group we started doing was a pregnancy group. Right when we started, we had a couple women who were doing wonderful prenatal education in the community, Lois Kaufman and Beth Elmore, and who approached us and said, we're doing these wonderful prepared childbirth kind of things, and it's almost all middle-class women. And we really think the people who could benefit the most from this would be some of your patients, and we don't have ways of really drawing them in. So we made an arrangement that they would do their classes at our place, and and our patients could get in free of charge to their classes, and it was great, and it was good. And then we found that we had more and more Latino women who were pregnant. A larger proportion of our pregnant women was Latino. And they didn't come to anything except the medical appointments. They came real regularly to medical appointments, and they wouldn't come to anything else. They wouldn't come to classes. They wouldn't come to nothing. And we had bilingual classes. We had monolingual Latino classes, Spanish classes. We had arranged the classes around their office visits, all kinds of stuff. Nothing worked. So we needed a new model of care. So we contacted some folks at Yale, who in the midwifery school, who were starting to develop a model of care called centering pregnancy. And there they get 6 or 8 women who are due at about the same time together for 2 hours, 8 to 10 times during the course of their pregnancy. And the first half hour of each meeting is, belly checks and listen to baby's heartbeats and blood pressure and weights and all that stuff. And then, as much as possible, you get the women to do that themselves. They check their own blood pressure. They check their own weight. And then the last hour and a half is spent in a circle with a provider like me or like Beth. Beth had rejoined us as a midwife by this time. And you spend time, an hour and a half talking about the things that these women care about. What's going on? And in the course of 20 hours together, you're bound to talk about labor, and you're bound to talk about breastfeeding, and you're bound to talk about all families, and you're bound to talk about child rearing, and all kinds of important issues. And the job of the professional is not to be the expert. The job of the professional is to host the meeting and to make sure that the life experience of each of these women comes into the circle. After a while, we found that we didn't have enough English-speaking people to keep an English group going. And so we were faced with a dilemma. Are we going to drop pregnancy groups, circles for English-speaking people? And we decided, let's try it with interpreters. We called folks at Yale and said, what do you think about doing this? Oh, don't do it. It'll slow things down. It won't work. I said, okay, fine. Thanks for your advice. We'll try it anyway. And we did it. And it was wonderful. Because now all of a sudden, people could only say one breath, and then they'd have to stop and hear it in the other language. And everything that was said in Spanish was said in English for everybody, and everything that was said in English was said in Spanish for everybody. And pretty soon, people were talking with much greater care and greater intentionality. Mm-hmm. And we were talking about all these wonderful cross-cultural things that were going on. And then there was one of our early bilingual groups like this. Beth was hosting. And there were, I think, 10 women in it. And 9 of them had their babies. And whenever they have their baby, they come and bring their baby in, and they tell their birth story to the whole group. And we always have food. You always have food when you're in a circle. You got to have food. Food and stories. Those are the 2 building blocks of community. And so 9 of these women had their babies. And then the 10th one had a stillbirth. And she gave permission for Beth to share that with the group at their next meeting. And at their next meeting, Beth shared this, and one of the other women in the group said, we need to go visit her. I mean, like, now. Mm-hmm. And Beth said, well, I'm not sure that's appropriate. And this woman said to Beth, Beth, I respect you as a midwife, but you don't understand our culture. We need to go see her now. And these 9 women piled into their cars with their babies and went to her house and surrounded her with care and affection and love. That lady eventually was part of 2 later pregnancy circles and has had a number. But it was a transformative thing for that whole group. Uh-huh. Here these women had found a group of support for each other. Many of them came from places where when they gave birth, they were surrounded by aunts and grandmothers and mother. And here they had a partner, maybe, if they were lucky. And so this group of women became their support. And so when they visited this woman, there were, all kinds of tears and stuff. But they brought her food, and they brought her consolation, and they grieved with her. And it was transformative. So you had a kind of community forming in the midst of that. Mm-hmm. Right there in pregnancy group.
With the translation and with the acknowledgement of, the tendency to have groups where there is just abundant commonality among people, but not necessarily the diversity that there could be, as you've brought this diversity of your community, of your neighborhood together, you mentioned bridging. Mm-hmm. We talk about bridging the gaps. Mm-hmm. So what are some other ways in which you've seen these circles, seen these spaces for community to form, where you've seen that bridging taking place?
Well, our board. So at the beginning, our board was made up of a bunch of local people. We organized really around 2 organizations. One was the parent-teacher organization at Chamberlain Elementary School, and the other was a tenants group that was organizing around housing in Ron David Heiser housing. And they were doing some very interesting things. La Casa was facilitating this. They would, on Sunday afternoon, take a van out to his church and invite his fellow church members to come in to Goshen and tour his apartments. And so it's some interesting, so it was creative stuff. And these people, so that's what we really organized around. And at the beginning, we had hillbilly hot dog sales, and people were knocking down walls in an old fire station, and there was lots of engagement for low-income folks. And then pretty soon, and we always had everybody, almost everybody on the board was patients. One or two exceptions, but almost everybody else on the board was a patient. And then pretty soon, we got to be a not-for-profit 501c3 corporation. And the job of the board is fiscal oversight, executive oversight, and policy oversight. And it's a real middle-class agenda. And gradually, all our low-income people just kind of drifted away. And we had a board that was made up, it was a fairly small board, but it's made up of very well-intentioned, dedicated, wonderful people who were almost all white middle-class Mennonites. And then one day I was writing a grant application, which I don't usually do for inspiration, but I was writing a grant application, and there was a question on there that said, how is the diversity of your community reflected in the diversity of your board? And I said, shit. So we deliberately then used that as an opportunity to go back and look at where in our organization is cross-cultural engagement happening at its best. And we decided it's happening in the pregnancy circle. And so the question became, how do we reinvent our board in the image of a pregnancy circle? So we went out and we invited a bunch of other people, a more diverse group of people to join the board. And we told our white middle-class Mennonite friends who were on the board, we said, we need you on the board, but we need you on a different board. A bigger board, a more inclusive board, and a board that works fundamentally differently. And then, so we had this wonderful, diverse group now. And then we had to do something different about our agenda. And we found that part of what happened in these pregnancy groups was people were telling stories. Stories at the heart of the circle. And how do we start making story be at the heart of how our board functions? And so we always meet on a Tuesday night. It's usually at 7 o'clock. It's always on 7 o'clock. We usually come in kind of tired because it's the end of the day. And we gather in a circle at the Yellow House right next to the healthcare center. We always try to have a little bit of food. And we spend the first hour in a story circle. We do it with interpreters because we have some people on the board who are monolingual Latinos. We have some people who are monolingual Anglos. And we have plenty of people who speak both. And then so we have the first hour is always a story circle. And there'll be a story question like, tell us about some time when you experienced unexpected hospitality. Or tell us a story about how money was handled in your family of origin. Or tell us a story about some time when you were in crisis and what did you learn about yourself. And then we'll go around the circle and everybody tells about 3, 4, 5 minute story. And we get to know each other. And we get to know each other well. And then, after we've done that, the second half of the meeting, the second hour, is what we call housekeeping, which is policies and budgets and all the other stuff boards usually do. But it's just kind of, it's the routine stuff. It's the housekeeping. And the important stuff in many ways that undergirds all that is the stories we've shared and the lives we've shared with each other in that context. So we have this diverse group of people. And then at 9 o'clock, we try to be done. And then people stand around washing dishes and talking and chatting. We've had board members who talk about this being the social highlight of their month because they're talking to people who have different kinds of experiences than they do. And they're talking to them about things that matter, things they care about, their lives. So it's another place where the circle process has brought very different people together and created places for bridging.
So on the, looking at your board and the decisions that do have to get made, with an organization that is, following, that is visioning, in a dynamic thing, there are two things that I'm curious to hear you touch on. One is, the idea of risk and having to take risks and step out at times awkwardly from the safety or the norms of what you've been doing. But also just, I think you even mentioned, bottom line earlier on. What is the bottom line for you then? I mean, oftentimes for an organization, the bottom line is the financial bottom line, and having to kind of, merge that or, manage that somehow with the mission. But bottom line doesn't have to just be financial. I mean, there's the triple bottom line that we talk about. But for Maple City, what would it be? And, maybe you can merge that with the idea of taking risks.
Yeah. Well, it's interesting. In most boards, in my experience, even when you have very risk-taking types people, people with vision, who, when they get together in a board or an organization, they tend to become more conservative. In the Christian faith, we tend to talk about the meaning of the resurrection is in part that we die to the fear of death. Death is still there, but we don't need to be afraid anymore. And so we can take bold risks in new ways. We can live boldly into a different reality because we need not live in fear. But in organizations, we usually think that the first job of the board, the first job of the organization, or of the administration, of everybody, is organizational survival. Which is clinging to things because you're afraid of dying. So organizationally, how do we die to the fear of organizational death? How do we move beyond that and say, there are worse things than us going under, right? So how do we kind of boldly move on? And I've been amazed in this kind of a board like we have, how we have people who end up being more risk-taking in the collective than they would be individually, which is sort of turning everything on its head. And we always ask the board, the only question that's really critical for the board is, how are we following the mission? How are we living out the values? How are we doing that? That is, we don't need bankers on the board. We have our own bankers, right? We don't need lawyers on the board. We have a lawyer. We don't need accountants on the board. We hire accountants. We hire all these people. What we need on the board is people who live the life in the community and who keep calling us back to saying, how are we living out our vision for a healthy community, and how are we living out the values of long-term relationships, integration, and empowering each other?
So I think it's safe to say that, through all of this approach, you've been successful. Maple City Healthcare Center is viewed nationally as a success story in many ways. You've found a way for this different economic model or approach to persist, to survive. You've gotten a lot of investment from other partners. And so speaking, from Maple City outwardly, what are some of those aspects of investment that are important for you, for people that people consciously are investing in? What do you see, being invested and being returned that's important for you that you would hope to see spread more broadly?
Well, it's always interesting to try to create the bridges, if you will, between the economy of trust and the economy of the bottom line. One of the places we have seen that is in our Medicaid population, for example, where because we build trust and we want people to come to us and not go to the ER, and we try to make sure we're accessible, we try to keep those connections going, our patients, Medicaid patients, cost the system consistently, quarter after quarter, year after year, 40% less than the state average. And at the same time, they're getting the highest quality scores in the state among Medicaid panels. How can you get the highest quality, lowest cost at the same time? Because we're not focusing on cost. We're focusing on building relationships, being in this together, keeping people out of that ER, okay? So all of a sudden we have an economy there of trust that gets great quality care for our patients. Now, we get to go, of course, who pays for, who gains this 40%? It's not the state, interestingly enough. In the state of Indiana, it would be impossible to run Medicaid services, healthcare services for poor people without giving somebody an opportunity to make a profit, right? A for-profit corporation. So we have for-profit corporations who actually run these things, and they're the ones that garner all this savings that we are working on. So we go to our insurance company and we say, look, guys, patients are getting the best quality in the state. You are laughing all the way to the bank. Who's doing the work? Time to ante up. Okay? So we get a one-of-a-kind kind of contract on that. We try to be business smart in those conversions. And then, a number of years ago, the hospital came to us and said, you guys are saving us a ton of money because so many poor people who don't have insurance are staying out of the hospital when they're your patients, instead of coming into the hospital with highly complicated cases because they have been neglected for so long. And you're saving us a ton of money. Why is there only one of you in town? We need more of you. So they invested $2 million overall. Well, various people did, but in Vista, and got us a second site with no strings attached except do it. Just use it. Expand. It's an interchange between a model of care that fosters community and has sort of great healthcare outcomes and great cost as side effects, and then trying to be business smart about saying, so how do we leverage that for some outside investment? That's been kind of part of the business side of trying to make it sustainable. And at the same time, when we started doing work with a hospital, I had real reservations about it. I mean, do I want to kind of, get in bed with this organization that seems to be functioning in fundamentally different ways? The hospital is fundamentally bottom line driven. We are fundamentally vision driven.
Right.
And if I can keep the hospital persuaded that a healthy community is good for business, and that we're thinking about healthy community broadly and long term, then we can maybe see an alignment between our approach and theirs. It's not going to be the same, but we can see an alignment. So we can work together. So we've been extremely explicit about those differences, the different strategies that that's going to cause, and the fact that this is at best an alignment. And that part of our job to maintain that alignment is to keep the hospital thinking broadly and long term about community health is good for business.
So there's in that current relationship as it stands, there's that reciprocity that provides an opportunity for you to challenge and advocate, but also continue doing, your pursuing your own mission.
And there's an explicitness about the differences we have.
Right.
So we're not pretending. We're not under any pretenses about being the same.
So I want to get around to questions, but first, that touches on the idea of growth, or speaks to the idea of growth in terms of, we can talk about growth in an economic sense and the challenges and the complexities of that, but for Maple City Healthcare Center, you're doing something well. You have grown recently. You went with the opening of the Vista Community Health Center. That's obviously a huge growth. How do you imagine growth continuing to happen for Maple City in a healthy way, or for the health of your community that doesn't get mired in some of the negative aspects of growth in the economy, or positive, depending on how you look at it?
Yeah, that's a big challenge. At some level, the organizational demands of getting bigger can be really oppressive for the kind of spirited ferment that one really wants to foster. I think one could easily argue that we would be better off and healthier if we were two separate health centers that were functioning as siblings instead of being one organization with two sites. We have some funding constraints from the feds that keep us from totally separating, and we're kind of working at that collaboration, how we work at that stuff between the two sites and make that work. But growth is not, I tend to think that the best growth is the growth of division, the growth of spawning off new local, small initiatives, see where it goes, see what happens. I mean, I feel fantastic about Clubhouse, where we were sort of somewhat involved in the origination of it, but it's totally its own thing with great staff, its own mission, its own kind of way of doing things. And it's like, oh, it is so nice to have Clubhouse here in town and to have folks back and forth between the healthcare center and Clubhouse, and to feel like it is not our baby sibling. It's not. It's a full-grown,
Yeah.
friend. So, but growth, yeah, that's a challenge.
Anybody have any questions?
You've partly worked at the growth thing geographically. You have said we have a limit, haven't you? Geographically to our patient base?
We have historically. So historically, when Maple City Healthcare Center started, and when it got its first federal grant, it was basically the northeast side of town. That neighborhood was our target area and so on. When we added Vista and got additional funding, we basically expanded the city limits in terms of our catchment area. We did. And we have a lot of patients who walk to the healthcare center. We have a lot of people from that neighborhood, and we still clearly have our strongest attachment there. But we do have patients from around town.
You talked about the beginning of the story when the mayor had a building and you had a vision. And how has the city government played a role in your story over the years?
It's largely been one of sort of facilitating our building at the beginning. We've had good relationships all along and have had a small community development block grant that a little bit of CDBG money that we get every year, but it's small. So we had a 20. We have these interesting leases that we arrange with different partners, So we get this fire station from the city, and they throw in $25,000 to renovate it, and then they give us a 20-year lease for $1 a year. And 5 years into it, we're doing a big expansion, and we say, we'd like to extend the lease. Can you give us another 20 years, make it a 40-year lease? And they said, we don't want to do that. We don't want to go that far out. So we're just going to go 20 years from now. So they extend it for 5 years total because it's only 5 years into the first lease. But then they add a little provision at the end that says, and if at the end of this time you're still doing not-for-profit healthcare, you can buy it for $100. Okay? So 5-7 years ago, we bought the place for $100. So we own the place now. We work at it. The city's been very cooperative with all the issues about expanding and building and parking and all that stuff. It's a mess to do that in a neighborhood. But that's been largely the extent of direct city involvement. But we've always had great relationships with public, and now we actually have one of the city council peoples on our board.
Yeah.
So I asked that question because my next question is, what's prohibiting your vision from just popping up in Plymouth and Bloomington and Elkhart and South Bend and whatnot?
What's prohibiting it?
The positive way of saying it is, why Goshen? Why did it work in Goshen? And is it transportable to other places? And what would...
So the whole issue of scalability and reproducibility is an interesting one. And I tend to think about what we did as sort of an experiment, if you will. And I felt like I did it very deliberately in very favorable terrain. So I went to medical school at the University of Chicago on the south side of Chicago, surrounded on 3 sides at that time by Black Ghetto, and on the 4th side by the lake, okay? And there was a level of poverty there that was much more difficult to figure out how you think about assets, okay? So I came to Goshen to do this in the lowest income neighborhood, but obviously still, there are a lot of resources around the town otherwise. And there are church resources, and there are medical resources, and there's a whole bunch of stuff to draw on, and Goshen has a culture of shared engagement that is very different even, I think, than Elkhart's culture. And I mean, not-for-profits work together and do things together in ways that are really pretty amazing in Goshen. So there's a sense in which this was an experiment, a modest experiment, in favorable terrain. Now, we're constantly asked by people, so how can we replicate your sliding fee scale? How do we replicate your model of team-based care? How do we replicate this? How do we replicate that? And I want to kind of say, you're looking at the wrong stuff to replicate. I mean, there are ideas there are things, sure, they're based in a philosophy of care and an approach to things. But what's really critical here is that you start in a community and you build relationships and you build on the assets of the people and passions of the people involved to address what's going on in the community. And that happens organismically and grows with the community. And it should, by all means, take a different shape in Plymouth and in Bloomington and in Indianapolis than it does here. Because this is something developed in a particular context, in a particular way, with particular people at a particular time and place. Similarly, I think about all of our policies and protocols and all those things. They're simply bridges between a kind of vision for the community and our lived reality. They're imperfect by their very nature. And they are contextual by their very nature. And so we constantly have to modify them. They're always a work in process. Everything we're doing is evolutionary. There is no model and there is no fixed vision. It's about being an envisioning community that grows together and is willing to take risks together for a common good. And I think anywhere you start doing that, the one thing, we don't create community. We can't. But we do guard a space for it to happen. And we find that the one thing that we can always be assured of when we guard that space is that something will surprise us. Something surprising happens. Whatever that's, Juan and Maria, what they did, that was a surprise that happened in a space that was guarded to protect dignity and care. And all of a sudden, something happened. The spirit moved in ways that were unpredictable. And so surprise is one of those wonderful gifts that we keep harvesting as we do our work. And I think anywhere else it happens, it's going to be different surprises. We can't replicate this, even in Goshen. I mean, whatever happens at Vista ends up being somewhat different than what happens at Maple City. Different people, different context, different space. Space is important. I don't know if that makes any sense.
No, that does.
One of the phrases you made, or one of the statements you made in a past conversation, or at least not too long ago, was pointing to the need for communal enterprise, for opportunities for us as members of a community to work together to bridge some of the perceived divides perhaps, but also to get things done. And maybe you could elaborate on that a little bit more here in terms of some of the ways in which you've helped create space for that through Maple City, but also how you see that potential here within Goshen, the common good, for that to happen more abundantly.
I'm going to digress just a little bit.
Sure.
I was on a board of the Indiana Primary Healthcare Association for a long time and continue to be a member of it. It's an association of community health centers around the state. And a number of years ago, they had a meeting in which they were all lamenting. These are CEOs of community health centers around the state, and they're all lamenting how expensive it is to buy health insurance for their employees. So they hired in somebody to come in and talk to them about how they can reduce their costs for health insurance for their employees. And in the middle of all this conversation, I finally kind of raised my hand. I said, so I'd like to understand, how many of you here offer free health care to your employees at your site? My hand was the only one that was up. I said, if you, as community health centers, believe that what you are doing in your communities is providing the best care that keeps your communities as healthy as possible and is good for your communities, why wouldn't you want to make absolutely sure that your employees are getting that care? A kind of schizophrenia about being the CEO of an organization versus being somehow involved in the community. Mm-hmm. That is to say that I think in some ways what we are trying to do in terms of fostering a healthy community, our primary work may not be in doing healthcare. In some ways, our primary work may be in what we do with our staff. Mm-hmm. And how we collect the staff and engage with the staff in ways that build a community of sufficiency and engagement and imagination where people really want to work together and work together well. Mm-hmm. And so we've worked at trying to make sure that everybody has a living wage. We have a really squished wage scale. Mm-hmm. It's really hard to raise a family on what a receptionist makes in Goshen, and so our receptionists make more. Mm-hmm. It's really easy to raise a family on half of what a doctor makes in Goshen. Doctors make half. Uh-huh. And then we have some single moms, for example, with 5 kids, who even with an above the normal wage scale kind of wage, can't make ends meet. So we have a living wage policy that those people get a 3rd check every month to bring them up. Mm-hmm. And then we have health care for everybody. And we have free health care at the healthcare center for everybody. And we pay 80% of deductibles, and we pay 80% of copays. And we have 8% retirement for everybody. And we have holidays for everybody. And we have paid time off for everybody. And we have 6 weeks paid parental leave, whether you're a father or a new mother, for everybody. And we currently have over 10 employees who are going back to college, and we're helping them do that and paying tuition. And then a few years ago, we had some of our medical assistants came to me and said, you know, when our kids were little, you guys helped pay for childcare for them so that we didn't have to worry where they were when we were at work. And now those kids are in high school, and we never got to go to college, but we really like our kids to be able to go to college, and we don't know how to afford it. So we started a program that pays $5,000 a year for every employee kid to go to college, to invest in them and their families. No real strings attached. It's about how do we make this a place where people have enough to thrive? Now, that changes how people engage in their work. It changes how they engage with our patients in their work. It changes how they feel about being in this community, about their work, about being part of this community of work. So recently, one of the last steps in new hires often is that they end up having sort of a group interview with the people who they're going to be working with. And one of our older medical assistants was overheard saying to a new hire, a new recruit, you know, when I come to work, I come to a holy space to do holy work. And when we invite you to join us, that's what we want to invite you to join. When you've got medical assistants and receptionists who think about their work that way and approach it that way, it's transformative. It transforms the experience for them. It transforms the experience for our patients. And so when I think about healthy community, that's every bit as much the mission as A1C numbers or blood pressure control or mammogram rates or vaccination rates.
No, I hear, yeah, and you're doing that internally with your staff. You're at these different, your internal community and expanding outward, and say, well, that's this integral aspect of Maple City, which shows up in all of these different endeavors.
Well, it's part of what makes it fun, because you don't have to try to remember, am I now in a board meeting? Am I in a staff meeting? Am I with patients? Which set of values is supposed to dominate here? Which set of principles is supposed to rule? No, it's all of a piece. It's a level of integration that we really do want to have. It's the sense of wherever we are, we're striving for this same community of engagement and abundance where everybody has enough and nobody has too much.
Why is this so important to you?
I think it's important to me because in some ways this is where I am striving to experience the kingdom of God breaking into our world.
I have gone to the 2 different facilities for help before, and I have really sensed a difference in the staff at these places. And I agree with, I don't understand your whole mindset, but I agree with you that it's good and right to have that kind of care for people. And it would be beautiful if that would just spread across the whole town of Goshen. And somehow I think that's kind of where you're at on part of that you could, just even with the hospital, try to get them to see things a little different and have that kind of care spreading that way.
Okay.
I think it was a year and a half ago now, maybe, we organized the panel discussion focused on the common good, health and healthcare, I think, in our community. And the transcript for that event is actually something we just published this past week in conjunction with this event. It was finally something that I pulled out and said, okay, I need to touch this up and make it accessible, because in going back and looking through it, there were just some observations that I think are really helpful for helping people appreciate, this changing context of healthcare in our community. But one of the things that I enjoyed reviewing were some of your ideas for, imagining what could happen here in Goshen. I mean, you talked about this as being a special place that did allow Maple City to grow and, live into some of its potential. So in that sense, I don't know if you would remember some of the things that you talked about. Of course, at that point, the fear was, okay, we've just had this electoral shift, and what's going to happen with the Affordable Care Act?
Sure.
And, what is there still this hope for single payer? Or what are the different scenarios that are out there? Well, what's the ideal scenario we can imagine? And especially within this context, the ingredients that we have here in Goshen.
Well, I think we have all kinds of opportunities here that it will be really exciting to build on. What would happen? Imagine, what would happen if we as a community said, as a healthcare community, hospital, physicians, everybody else, in this community, no one will go without basic health care. We will make sure that we structure the provider community in such ways that everybody has a medical home that's accessible and affordable, where they can get preventive, acute, and chronic care when they need it. That includes behavioral health and dental care. And we say, this is something that we as a community say is part of who we want to be as a community. Now, if you, as business people, want to operate here, welcome, okay? But this is who we are. What does that do for business? What does that do for a community? What does it do for investments? What does it do for our sense of ourselves? What does it do for our schools? If we start thinking that way about our schools too. That this is part of how we want to define ourselves, that we are a community where we take care of each other and where there is enough. And you know, we're probably spending more money now on healthcare than it would take if we did it that way. So what happens if we start imagining that?
Are there any ways, as a community, we can create space for that imagination at that level?
Well, that's interesting. I mean, yeah, how do we, in my experience, it's still interesting how our medical community globally, I mean, I'm not talking just narrowly locally, I don't want to impugn people, but we have essentially created a whole training system for physicians that creates a whole set of people who are extremely privileged and feel somehow entitled to more, feel deprived. I mean, that's peculiar. And we live in a whole culture now of so much fear. And I think fear just fundamentally undermines our ability to imagine really transformative new structures. So the first step is, how do we start stepping out of that fearful stuff? Look, we can work this together, and there's enough for all of us if we do it together. I mean, one of the things we work at the healthcare center all the time is, how do we get away from individual entitlement benefits to shared collective benefits? Because they're much more sustainable and much more affordable and much better. It's like, there's a study out there, this may be a stretched analogy, but there's a study out there that shows that people who eat lunch are more productive in the course of their day, who take a lunch break, are more productive in the course of their day than people who don't take a lunch break. Okay? Now there's a study, an elaboration of that study that suggests that people who actually sit down with other people in a shared space for lunch or shared time are more productive than if they just eat lunch by themselves at their desk in the course of the day. And if they actually eat shared food, not just a shared space, not just a shared time, but shared food, they're more productive. How do we get to a sense that when we do this stuff together, we have opportunities that we can't even imagine? We're getting there in some ways. I mean, right now we have some incredible collaborative arrangements with the hospital. They accept our sliding fee scale determination, financial determination for any of our patients. And they can get any service that's available in the Goshen Health System, inpatient, outpatient, specialty, anything, at sliding fee scales, discounts. Now, without having to go through Goshen Hospital's finance department or stuff to do it. All they need is a letter from us that says where their stuff is. That's amazing. I mean, you know, all these specialty services available at dramatic discounts for low-income folks. We now, for the first time, have had actually a few people in hospital practices approaching us to say, you know, I'm kind of tired of working here. It'd be kind of interesting to work in a Maple City environment. Now, up to now, we've only ever recruited, you know, individuals and sort of grown amoebically, organismically. The notion of what would happen if we took over practices, I mean, the hospital would be threatened to hell, you know, and we have to work things out. But it's an interesting idea that there are people yearning for transformed practice. And how do you start letting that leaven work?
There was so prior to the event, you shared a story that you might weave in here that speaks to the, yes, we are having to bridge different, political gaps here, different understandings, and there is the economics of what you're doing do have this potential to do this in more cost effectively. Do you want to share the story with Carlin Yoder? About showing that we don't have to project outward this pattern that this is the divide. The divides aren't always what we see.
Yeah. So a number of years ago, Carlin Yoder, who was a state senator, we invited him to come meet our staff, visit our site, get a sense of what we're doing. And he came. And he must have been in a bad mood that day or something. I don't know. But he kind of started. I mean, we had staff here. The whole staff was together for lunch. And we had staff who'd been cooking all morning to prepare this lovely homemade feast, for everybody to share together. And he kind of approached it with this attitude like, I get a dozen constituency events I get invited to every week. Why am I wasting my time with you guys? And my answer was, well, because we're saving you a shitload of money. And I got his attention. And we had conversations over lunch about a whole bunch of things. And at the end, he sort of exemplified his frustration with the healthcare system by telling a story about his daughter, who he and his wife were out of town for a weekend or something, and she was staying with grandparents. And during that time, she developed a bellyache, and they ended up taking her to the emergency room, and she had a CAT scan and this and the other thing, and she ended up with a $5,000 bill for gas. Okay? That's the problem with healthcare. I said, well, let me tell you a story that happened just the day before, where I had a phone call at about 2:30 in the afternoon from a 30-some-year-old patient of mine who had no insurance and didn't speak English. And he was having some belly pain. And it started kind of here, and it went kind of here, and I was kind of worried about it just on the phone, what was going on. I said, I want to see you right away, come into the office. So he came into the office about a half an hour later. I saw him. I thought he had appendicitis. I said, look, urine is clear. I need to get a blood count. And if I do it here in the office, I won't get the results till tomorrow. That's too long. So I'm going to send you to the hospital for a blood test. I want you to go to the laboratory. I want you to get this blood test. And I want you to sit down in that laboratory waiting room and refuse to go to the emergency room until you hear from me. Do not let anybody take you to the emergency room. Go to the lab, get the test, and then we'll go from there. Went to the lab, got the white count, was elevated. I was convinced he had appendicitis. I called the surgeon on call. I said, I've got a patient of mine who's sitting in the laboratory of the hospital lab, in the waiting room of the hospital lab, who has appendicitis and needs to see a surgeon. Can you guys see him now? And she said, well, just send him to the ER. I said, he doesn't need to go to the ER. He doesn't need to see an ER doc, and he doesn't need a CAT scan, which is the first thing they're going to do. He needs to see a surgeon. So I'm giving you a choice. You or one of your partners can see him this afternoon in the office, or I'll admit him to the hospital and ask for a consult, and you'll see him in the hospital this afternoon, but he won't go through the ER. They made arrangements for him to see one of the partners in the office at 5 o'clock. So the partner in the office at 5 o'clock, guy agrees he has appendicitis. 8 o'clock that evening, he has outpatient appendectomy at the hospital and goes home at 10:30. Never got a CAT scan. Never saw an ER doc. Never had any laboratory tests he didn't need. He got timely care. He got excellent care. He got great outcomes. And it was extremely cost effective. So I said to Carlin, so what was the difference between your daughter and my patient? I think the difference was that my patient had a medical home where we'd go to bat for him. Well, I kind of felt like I stuck it to him, thrown it out there, whatever. To hell with that relationship, right? A few months later, I was down in Indianapolis at the Indiana Primary Healthcare Association meetings, and they have a lobbyist who goes around and hobnobs with all kinds of people and this and that. And he was talking about how important it is for community health centers. There's a meeting, a couple hundred people, talking about how important it is for community health centers to talk to their local political figures, their Congress people and their state house people, because making connections is really important and all that stuff. And then he says, and by the way, don't assume that your take on these things is always accurate on how things go. I mean, Gingerich over there had an interchange with his representative Carolyn Yoder a couple months ago that he thought went really bad and kind of went down the toilet. And I was at a reception just 2-3 nights ago with Carolyn Yoder, and he couldn't stop talking about all the great things that are happening at Maple City Healthcare Center in Goshen. So you never know.
So, James, is there anything else you want to touch on here this evening before we wrap up?
I'm fine.
Thank you very much for providing a medical home here for me and many others here in Goshen, and for sharing with us here this evening.
Well, thank you for this opportunity and for the work you're doing here.